Okay, thank you for inviting me here again. I'd like to introduce our company. It's RegenInnopharm. It means innovative drug for regenerative therapy. What do you mean by regenerative? It means we don't use stem cell for regeneration. Rather, we use a molecular platform for regeneration. So that's the key concept of our company. Basically, our concept is to use microRNA-based approach to activate the in vivo repair program in response to injury signals. The main point of using microRNA is that it can activate multiple gene cluster so that we can have the multimodal action for regeneration in order to get more efficient therapeutic outcome that has not been possible before by using conventional single mode of action. That's the key concept of our company. Currently, we have three forefront pipelines, one for stroke and one for AMI. These two are in the late preclinical stage. The other one is for diabetic foot ulcer, which is now IND approved and ready for phase 1 clinical trials. Let me briefly go over for each of the items for three. The first one is the cell-penetrating RNA ASO for AMI. What it does is that, as I mentioned, it has multimodal actions. Either activate the regenerative program or suppress the damage program for the protection of the heart after myocardial infarction. Using this concept, we tried to demonstrate its efficacy in the pig model, which is most close to human model. So when we injected our drugs into myocardial infarction of the pig, we could see that upon myocardial infarction, the left ventricular ejection fraction is rapidly going down. But within 4 days after treatment, our drug-treated groups, they rapidly rise up to almost 90% normal value being recovered from the myocardial shock, whereas the control group is continuously getting deteriorated, leading to congenital heart failure. Similarly, for the remodeling of the heart, while the control group is showing continuous distension of the myocardial wall, leading to cardiac failure, but the treated group maintain the normal integrity of the heart. So this is the key concept, showing that we can recover the heart within 4 days after infarction up to the normal level of the before myocardial infarction. So in order to demonstrate this concept in a more strict way, we use the larger animal model, larger number of the pig, and use the cardiac MRI in collaboration with Austrian group and the Hungary group. What it shows is that, as we saw before, the LVEF level is rapidly rising up within 4 days compared to control group, and the infarct size is going down within 4 days, significantly different in the control group. So it's confirming it's our concept we initially saw. So in order to compare the efficacy of our drug in a multiple comparison, we performed the meta-analysis amongst many of the global preclinical study using pig model. As you see, for the percent LVEF increase, this is the size of the effect from the mean size. This is red colored one is our drugs. We show that the magnitude of increase in the LVEF is largest amongst all these comparison, and the decrease of the myocardial infarction is also biggest compared to other drugs, because the percent LVEF and the infarct size is two most critical risk factor in AMI. So I could say that our drug is very unique drug that can both increase the percent LVEF and decrease the infarct size. So in that sense, we would say this is the first drug that has been ever developed. So we hope that this could have a similar effect in the clinical trials. Second drug is the peptide drug for stroke. These are the Lin-28 mimicking peptide. Therefore, it can simulate neurogenesis, and it can also block the neuroinflammation induced by microglial activation or astrocyte polarization. So it has also multimodal actions. What you can see from the red model of the stroke is that we could decrease the infarct size in a dose-dependent manner. By one single injection, we could decrease up to 80% of the infarct size with just one injection. And those changes were accompanied by changes in the neurological behavior. So in the corridor test, the treated group was behaving almost like a normal, meaning it can have the straight walking, while the control group has a waggling gait. So these concepts, in order to be confirmed in the primate model, we used the rhesus monkey. And the neural sequelae in the primate model is scored by NHPSS score. As you can see, compared to control group, the treated group shows almost 70% decrease in the NHPSS score. To my best knowledge, this is the biggest difference in the primate model in this terms of the neurological sequelae. So we have the hope that it can have also similar therapeutic effect in human model, decreasing the neurological sequelae. So this is the impact we think for this asset. Means just by one single IV injection, it can decrease the infarct size up to 95%, and it can also decrease the neurological sequelae. So with just one injection, you can have the difference in the quality of life. Because most of the patients of the stroke, they need at least 1 year of the rehabilitation care. So with just one IV injection, we can significantly decrease the need for rehabilitation care, because the quality of life is becoming much better than being untreated by these drugs. The last item is the peptide for diabetic foot ulcer, which is another unmet need disease with a continuous progression of the inflammatory score. To say the long story in short, in the diabetic pig model, we could see the acceleration of the wound closure compared to control group or the similar control group of the EGF. We could see apparently higher level of the wound closure, but not just this acceleration of the wound closure. The quality of the closure itself is different. You see compared to control group, you see more intact structure of the skin by treating this group. So meaning that more intact recovery of the skin is possible with this drug. But most important thing is that so far many of the failure has been reported in diabetic foot ulcer because they could not solve the ischemic complication, or they could not have enough re-epithelialization process, or the wound itself is fragile, meaning recurrence is possible. But in our drugs, it shows apparently higher level of the tight junction is by JO1. So the control and the EGF treated group has vascular leakage, but our treated one does not have any vascular leakage, meaning that non-leaky, healthy vessel is being produced. It's not just repair. It's totally regeneration of these normal tissues. So we can see the higher level of the healthy vessels, and we can see also the higher level of re-epithelialization, and in terms of the area of the epithelially covered area. And the other one is the mechanical strength. We see higher level of the granulation tissues and the elastic fiber. Normally, elastic fiber is not well produced in the wound repair, but we see that those higher level of mechanical power is supported by elastic fiber. So to say the long story short, this is the first drug that has a potential to overcome the previous hurdles of diabetic foot ulcer for comprehensive treatment of DFU, which can overcome many of the serious complications, and so many of the hurdles can be overcome by these drugs. So our company is trying to make some sort of the contribution to change the standard operating care for intractable disease, so that we can really contribute for the health care. Yeah, thank you.
Can you speak to the sustainability of the treatment? Have you been able to follow over months and years?
Yep, that's a great question. For AMI, we did follow, although I showed only 4 days, we checked up to I cannot go back. We did up to 3 months follow-up, and we could see the maintenance of this effect for 3 months. In the pig, the 3 months in pig is equivalent to 6 months to 1 year in human model. So we found that it is well maintained during the period. Yes. Yeah.
If I hear correctly, when you were showing the brain image, you talk about inflammation. Is that correct?
Yes. Inflammation as well as the neurogenesis.
Right.
Yeah.
So I can see the significant decrease,
Yes.
right, in your case.
Yes.
What if you were to have something that can remove cytokines at the same time from the brain?
Cytokine? You mean cytokine?
Cytokines.
Yeah. We measured those level of cytokine actually because during the cerebral stroke, the LAT7 microRNA sharply increased, as you know, and LAT7 itself is the ligand for toll-like receptor signal, and TNF receptor, TNF or the IL-6 is sharply increased,
Right.
and the level is decreased by this drug because this drug is working like a LIN28, so they suppress the LAT7, so they completely shut down the neuroinflammatory activity, and also the astrocyte from A2 to A1. I mean, A2 is, A1 to A2, so they can have more reparative phenotypes. Yeah, you have both phenotypes.
So if you have both, they will better.
Yes.
Let's talk.
Yeah, yeah, that's a good point. Because also, you have the neurogenic effect. It promotes neurogenesis. If you have only a single mode of action, you can only choose one of them. But with this microRNA-based drug, we can have both together so that we can have a comprehensive therapeutic outcomes. That's the key point. Yeah. Oh, you do?
Oh, I can just talk.
Yeah.
I work for, I represent here Cytostorm, and we remove cytokines, L6 and L8 and all of those. Let's go.
Okay. Thank you so much.